Good morning, Ma'am Reese. Good morning, Doc Aaron. Good morning, classmates. So our group was given the case study about sepsis. Before the SEPSIS 3 publication, sepsis was known as a syndrome resulting from the host response to infection. Its definition was based on the systemic inflammatory response syndrome, or SIRS, developing from the documented or suspected infection. The SIRS criteria needed to have at least two of the following: a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, pulse greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, or an arterial gas flow of less than 32 millimeter mercury, white blood cell count greater than 12,000 cells per millimeter cube, less than 4,000 cells per millimeter cube, or greater than 10% immature band forms. Sepsis, according to SEPSIS 3 guidelines in 2016, is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is seen in patients with sepsis who develop underlying circulatory and metabolic abnormalities resulting in hypotension that require vasopressors to maintain an MAP of greater than 65 millimeter mercury and having a serum lactate level of greater than 2 millimosmoles per liter despite adequate volume resuscitation, resulting in higher risk of mortality. Symptoms of sepsis can include a fever, chills, very fast breathing, and a very fast heartbeat. Symptoms of severe sepsis can include acting confused or feeling lightheaded or dizzy, trouble breathing, cool, clammy skin or red flushed skin, poor appetite, urinating much less than usual, different types of skin rashes, belly pain or cramping with diarrhea, and other problems with the heart, kidneys, or brain. It is noted that people who have septic shock have many of the symptoms listed above, plus their blood pressure gets low and they sometimes pass out. Based on the case study given, we have gathered the following data. Patient's name, James Stallings, age 84 years old, male, height 178 centimeters, with a weight of 78 kilograms, allergic to codeine causing nausea and ramipril causing cough. Medical history includes BPH, type 2 DM, hypertension, atrial fibrillation, CVA, and depression. The chief complaint is confused and not responding, looks pale and fatigued. Admitting our current diagnosis of SIRS, sepsis, and septic shock. Has undergone enteral feeding, and the patient was given doxycycline 100 milligrams twice daily, 3 days prior to admission for respiratory infection. Based on the laboratory exam, the patient has slightly increased magnesium and chloride levels and eGFR of 24 milliliter per minute, and prolonged PT time, elevated INR, decreased hemoglobin and hematocrit level, and an elevated WBC. The patient was given the following routine or standing medications: metformin 850 milligrams twice daily for type 2 diabetes mellitus, losartan 25 milligrams daily, metoprolol 50 milligrams daily for his hypertension, sertraline 100 milligrams daily for depression, finasteride 100 milligrams daily, and terazosin 5 milligrams at night for his benign prostate hypertrophy, warfarin 5 milligrams every Mondays, Wednesdays, and Fridays, and 7.5 milligrams every Tuesdays, Thursdays, Saturdays, and Sundays for venous thromboembolism or atrial fibrillation, and doxycycline 100 milligrams twice daily for bacterial infection. All of this without the starting date, time, and the stop date. The patient was also given the following IV medications: 0.9 sodium chloride 500 ml bolus, norepinephrine with a current rate of 15 micrograms per minute, vasopressin with a current rate of 0.04 units per minute. All of this without a starting and stopping date and time.
Drug therapy assessment worksheet. Type of problem, completeness and clarity of drug order. Is the drug order written illegibly? No problem exists. Is the drug order incomplete? A problem exists. Warfarin has no clear frequency as to how many times in a day given. Are there any forbidden abbreviation used in the order? So more information is needed for a determination of tirazosin 5 mg per oral at bedtime. Is the drug order ambiguous? Warfarin is taken once a day, usually in the evening to maximize its effect. HS at bedtime, hours of sleep, mistaken as half strength, so instead use all uppercase letter of HS for bedtime. Correlation between drug therapy and medical problems. So are there drugs without a medical indication? No problem exists. Are any medications unidentified, unlabeled, or unknown? So no problem exists. Are there untreated medical conditions? So a problem exists. Inappropriate medication management given for symptoms of sepsis and septic shock. So do they require drug therapy? A problem exists. The patient requires additional drug therapy. Appropriate drug selection. So what is the comparative efficacy of the chosen medication? The IV route does better than the oral route because the medication is delivered directly into the bloodstream rather than having to be absorbed to the stomach when treating for the critically ill patient. So what is the relative safety of the chosen medication? The patient is currently intubated, so therefore his current oral medication should be discontinued, then switch to IV medicine to treat patient's condition. It is relatively safe following the guidance for sepsis. So has the therapy been tailored to this individual patient? So a problem exists. Warfarin is not tailored to patient because the dose of warfarin depends on the proton beam time and other appropriate coagulation tests. So for elderly, dose reduction may be required. Are there any contraindication on the use of drugs or ordered to the patient? So a problem exists. Losartan 25 mg oral tablet and metoprolol succinate 25 mg is contraindicated to the patient with high BUN and serum creatinine.
Appropriateness of dosage regimen. Are the prescribed dose and dosing frequency appropriate within the usual therapeutic range and or modified for patients' factors? A problem exists. IV medication is more effective for sepsis than oral medication, warfarin, metformin. Is the dose inappropriate based on drug or patient-specific information? A problem exists. No, oral medication doesn't meet the optimal treatment of the patient's current status. Is PRN use appropriate for those medication either prescribed or taken that way? No problem exists. Is the route, dosage form, mode of administration appropriate considering efficacy, safety, convenience, patient's limitations, and cost? A problem exists. Due to the patient's high BUN and serum creatinine, his age, low blood pressure, and probable sepsis based on the signs and symptoms. Changing dose or adjustment and discontinuation of medications are to be considered. Metformin 800 mg, Losartan 25 mg, metoprolol succinate 50 mg, sertraline 100 mg, finasteride 5 mg, tirazosin 5 mg, warfarin 5 mg, doxycycline 100 mg per oral. Is the time of administration inappropriate to maximize efficacy and minimize adverse effects? No problem exists. Are doses scheduled to maximize therapeutic effects and compliance and to minimize adverse effects, drug interactions, and regimen complexity? A problem exists. Concomitant intake of warfarin and doxycycline may enhance the anticoagulant effect of vitamin K antagonists. Is the length of course therapy appropriate? More information is needed for determination. Therapeutic duplication and drug allergy. No problem exists.
Adverse drug events. Are there symptoms or medical problems that may be drug-induced? What is the likelihood that the problem is drug-related? Yes, a problem exists. Metoprolol 50 mg, losartan 25 mg, and tirazosin 5 mg may cause lowering of blood pressure of the patient. Is there a high alert drug prescribed to the patient based on drug watch list? Yes, norepinephrine, vasopressin, and warfarin. Interactions. Drug disease, drug nutrient, nutrients, and drug laboratory tests. Other drug-drug interaction, yes, a problem exists. Warfarin with doxycycline, terasacin and metoprolol, warfarin with sertraline, metformin and warfarin, metformin and sertraline, metformin and metoprolol. Are they clinically significant? Drug interaction can potentiate a medication's effect, possibly triggering a response similar to overdose, reduced effect, or entirely ineffective to patient. Also could lead to drug-induced disease. Are any medications contraindicated relatively or absolutely given the patient characteristics and current or past disease states? More information is needed for a determination. No problem exists or an intervention is not needed for both drug-nutrients interactions and drug laboratory test interactions, and they are both no clinically significant. Physicochemical incompatibilities. Are there drugs administered as an IV admixtures? Yes, but suprasin and norepinephrine. Are there any significant physicochemical incompatibilities? No problem exists or an intervention is not needed. Compliance and adherence. Is the patient non-compliance based on the medication treatment record? More information is needed for determination. The patient's current mental status is much more altered than his baseline. Is there any written reason in the patient's medical chart? Yes, the patient had a stroke within the past.
In transcription and financial impact, no problem exists or an intervention is not needed. Failure to receive therapy. Has the patient failed to receive a medication due to system error or non-compliance? No problem exists or an intervention is not needed. Are there factors hindering the achievement of therapeutic efficacy? A problem exists. Patient age, existing medical condition, and drug-drug interactions. Social or recreational drug use, no problem exists or an intervention is not needed. Patient knowledge of drug therapy. Does the patient understand the purpose of his or her medications, how to take it, and the potential side effects of the therapy? A problem exists. The patient is in his old age and has a small memory deficits post-stroke that could possibly lead to the non-compliance of his medication. Would the patient benefit from education tools? Education tools would favor the patient in improving his condition and increase chance of prolonging his life. Such would educate and guide the patient's family in achieving health goals.
Pharmacist intervention. Patient name, Stallings James. Our first pharmacist intervention is for therapeutic appropriateness. For subjective and objective, past medical history of type 2 diabetes mellitus for 9 months. Glucose is 205 mg per deciliter BUN of 45 mg per deciliter and serum creatinine of 2.6 mg per deciliter. The current drug therapy of use is metformin 850 mg per oral twice a day. For our assessment, monitoring is needed to assess effectiveness or response to therapy. Patient is intubated. Our plan of care involves weighing benefits over risk. Suggest the medication order metformin 850 mg per oral tablet to insulin IV. Start insulin sliding scale to keep blood glucose lesser than 150 mg per deciliter. Patient with high glucose levels should receive insulin and glucose with frequent blood glucose monitoring. Every hour initially, then every 2 to 4 hours once glucose levels have stabilized. Our team's next pharmacist intervention involves potential drug-disease interaction. Our given data of subjective and objective is for the use of PT-INR, which is 37.5 seconds and 3.6 respectively. Current medication for anticoagulant, which is warfarin, is used. For our assessment, elevated INR and high PT may mean patient is at risk for dangerous bleeding and possible serious liver damage or cirrhosis. So for our plan of care involves weighing benefits over risk. Suggest to discontinue medication order of warfarin per oral. Next one would be for the additional drug therapy. Signs and symptoms and laboratory result was used for the subjective and objective. Additionally, current antibiotic doxycycline 100 mg per oral twice a day, and the patient received numerous fluids boluses with IV crystalloid therapy. For our assessment, additional drug therapy is required. Our plan of care involves weighing benefits over risk, suggesting the medication order of doxycycline 100 mg oral tablet to be switched to more effective broad-spectrum therapy as follows. Starting vancomycin 1 gram IV once daily to be adjusted based on optimal trough concentration, plus recommend administering piperacillin tazobactam 2.25 every 6 to 8 hours IV or meropenem as first and second line antibiotics respectively. Crystalloid fluid of 0.9% sodium chloride bolus given within the first 3 hours or up to 10 liters per day. Patient MAP is 63 millimeters of mercury and unable to restore hemodynamic stability. So we're suggesting starting hydrocortisone 50 mg to be given every 6 hours or 200 mg per day. Corticosteroids have been advocated as adjunctive therapy in patients with severe sepsis and septic shock, as they prevent release of pro-inflammatory cytokines. For our team's next pharmacist intervention, current medication is used for our particulars for our subjective and objective. Our assessment would be for the goal of therapy of sepsis as for our patient is intubated. Our plan of care involves weighing benefits over risk, suggesting to discontinue all current oral medication and changing them to IV equivalent treatment if available until patient's hemodynamic is stable. Another pharmacist intervention involves the use of patient's weight and laboratory results as our particulars for our subjective and objective. Our assessment determines the use of additional adjunctive therapy is needed. Our plan of care involves weighing benefits over risk, suggesting to start giving adjunctive therapy as follows. Patients should receive approximately 25 to 27 kilocalories per kilogram body weight and 1.5 grams protein per kilogram. This recommendation changes to 20 to 25 kilocalories per kilogram and 1.5 to 2 grams protein per kilogram for acute phase patients, continuing the nutrition until the patient meets 50 to 65 of their caloric needs within 48 to 72 hours of hospitalization. Enteral nutrition is recommended in sepsis patients to meet the increased energy and protein requirements.
These are the non-pharmacologic interventions. First, monitor and control blood pressure, then check blood glucose level regularly. Close monitoring of laboratory results such as urine output, pH level, and serum lactate. Then sedentary lifestyle support. Then discussing goals of care and prognosis with patients and families, and suggest addressing goals of care. We also recommend the principles of palliative care, which may include palliative care consultation based on clinician judgment, be integrated into the treatment plan when appropriate to address patient and family symptoms and suffering, assessment and follow-up for physical, cognitive, and emotional problems after hospital discharge, and prayer and support from the family and friends. The summary of our case. The patient's name is James Stallings, who was diagnosed with BPH, type 2 DM, hypertension, atrial fibrillation, cerebral vascular accident, and depression. He presented symptoms and laboratory tests consistent with sepsis. Vital signs, physical examination, and diagnostic tests were performed to confirm the cause of his current diagnosis, except for laboratory cultures that are still pending. EMS medic reports that the patient was hypotensive with SBP in the 90 mmHg and was subsequently given 0.9% NS 500 ml bolus, and noted that the patient was not aware of his current situation, presenting small memory deficits post-stroke. After receiving numerous fluid boluses with IV crystalloid therapy, norepinephrine and vasopressin has been initiated, but the patient remains hypotensive, tachycardiac, and now intubated. Patients with suspected sepsis should receive early hemodynamic support with intravenous fluid followed by vasopressors as well as early empiric antimicrobial therapy. In the resuscitation from sepsis-induced hypoperfusion, to give crystalloid fluid of 0.9% sodium chloride bolus, at least 30 ml per kilogram, given within the first 3 hours or up to 10 liters per day. The patient's sepsis source is still unclear. Administration of broad-spectrum anti-infective therapy of vancomycin 1 gram IV once daily to be adjusted based on optimal concentration, plus recommend administering of piperacillin tazobactam or meropenem as first and second-line antibiotics respectively. Vasoactive medications of norepinephrine with vasopressin up to 0.03 units per minute with the intent of raising the mean arterial pressure of greater than 65 mmHg target. Patient MAP is 63 mmHg and unable to restore hemodynamic stability. To start, IV hydrocortisone 200 mg IV infusion per day. Monitoring of patient hemodynamic and inform families about long-term outcomes. The following are the Surviving Sepsis Campaign Bundle, the Hour 1 bundle, with the references. And our case presentation has ended. Thank you very much for listening and good morning, everyone.